Great. Hi, everyone. Good morning. Good to see you for day 3, technically, but day 2 of our sessions together. My name is Jordan Lawrence. I am an assistant professor in the Department of Epidemiology and Biostatistics, and I have the wonderful privilege of introducing our keynote speaker today. So Dr. Michelle Morse, in addition to being an amazing thought partner as part of the reparations work that we do, Dr. Morse is, most importantly, the acting health commissioner and chief medical officer of the New York City Department of Health and Mental Hygiene. There, she leads the agency's work in bridging public health and healthcare to reduce health inequities and serves as a key liaison to clinicians and clinical leaders across New York City. She previously served as Deputy Commissioner for the Center for Health Equity and Community Wellness, where she led place-based and cross-cutting health equity programs. Dr. Morse is an internal medicine and public health doctor who works to achieve health equity through global solidarity, social medicine, and anti-racism education and activism. She is a general internal medicine physician, part-time hospitalist at Kings County Hospital, co-founder of Equal Health, and assistant professor at Harvard Medical School. And it is an honor to hear your talk today. Please come to the stage.
All right, good morning, everyone. It is good to be home in Philly, specifically in West Philly. I grew up the street at my dad's funeral homes at 40th and Haverford, and I went to med school at Penn around the corner, and I also went to Powell Elementary School, so it really is good to be home. And when the dean reached out to invite me, I said, obviously, any chance I have to come home to West Philly and talk about health equity and public health, I'm here. So it's really nice to be with you. And I'm sad I missed Dr. Bassett yesterday, but I heard her talk was phenomenal. She was texting me, telling me that it was really wonderful to be with you all here. So with that, I will jump right on in. And I'm only going to speak for maybe like 20 or 25 minutes or so we have time for lots of discussion. And I really look forward to the questions and the reflections and any comments you all might have. So I hope you're jotting down your reactions as I speak. So, like I said, there's no place like home. It's good to be home in Philly. I'm really honored to get to kick off the day today. And it's really important to be here talking about the roots and foundation of public health in a time when, as we know, public health is under attack in all kinds of new, creative, evil, genius ways. I was just reflecting the days and the weeks go by very, very quickly in public health right now, especially being on the front lines and specifically being on the front lines of the largest local health department in the country in a city that is going through its own profound political challenges that I'm sure many of you have read about in the news. But specifically, I was reflecting just on my first half of my day yesterday. And I'm sure someone's going to ask me this question: how do you stay hopeful? And it's a hard question to answer right now. But I will say that my first half of the day yesterday was an emergency meeting about COVID vaccine access, an emergency meeting about our health insurance program that is likely to be reduced significantly in New York State. We're one of 3 states in the country that has a basic health plan, and there are 1.5 million people across the state that are on this basic health plan. It's a phenomenal plan, and it is going to shrink considerably because of H.R. 1, the budget reconciliation bill that was passed over the summer. And then the third meeting was an urgent meeting about a city council hearing where I'm going to be testifying about our response to our Legionnaires cluster. So that was just the first 3 hours of my day yesterday. It is a very, very intense time, but a very important time to be in public health. But all that said, again, it's good to be home. I grew up, like I said, in West Philly. And I learned a lot growing up in this neighborhood. One of the most formative pieces, I would say, of my education happened at the funeral home that my father runs, that I mentioned, that's just up the street. My dad's the third generation running our family's funeral home. And growing up, of course, it was hard to not notice who my father was burying. And before I had the vocabulary for, what we say in public health is the demographics of death, I knew that he was burying too many Black people far too young. And that's really how I began to learn the patterns of who our society values. Life expectancy, as I'm sure you all know, for Black men in Philadelphia is 65 years. And at the New York City Health Department, we categorize death at 65 or younger as premature death. And yet, for Black men in Philadelphia, dying before their time is basically the expectation at baseline. That is not an acceptable expectation for anyone, and there's no currency more valuable than time. In the New York City Health Department, we're doing all we can to give everyone more time with the people they love, especially people who've been robbed of that time across generations. So my work and my journey, my public health origin story, I guess, started right here in Philadelphia. But as you know, public health, of course, has an incredibly long history, and so many people and generations of frontline public health workers before us and me have pushed back against health inequities. And just an aside, this is the 220-year anniversary of the New York City Health Department. We are having a week-long celebration 2 weeks from now, including people like Georges Benjamin coming to speak with us about what the history of public health means right now. And particularly, again, being the first local health department in the country, we felt it was a very important time to celebrate our founding. So with that said, I see our work today in public health as a continuation of the practice of social epidemiology that began with Du Bois right here in Philadelphia. His seminal work, The Philadelphia Negro, put the blame for inequitable health outcomes squarely on the shoulders of a larger society that abandoned their responsibility to Black Americans. In 1899, 126 years ago, he wrote, "The most difficult problem in the matter of Negro health is the peculiar attitude of the nation toward the well-being of the race." There have been few other cases in history of civilized peoples where human suffering has been viewed with such peculiar indifference. And now, of course, we're still living under the weight of that peculiar indifference, or maybe it's changed from indifference to active demonization. We, of course, are watching its consequences play out across cities in America to this day, and it's time for us to move from indifference to reparative action. All of us have a role to play to make that move, but we can do that only if we understand that we're all working within a health landscape that's profoundly shaped by racist systems. In New York City, we can literally map the inequities across the 5 boroughs. New York City operates, of course, as a collective of unique neighborhoods with lots and lots of different resources, challenges, languages, and the communities we serve constantly carry the weight of those inequities. These maps say nothing about the individual faults or responsibilities. Instead, these are the consequences of systems and structures that consistently prioritize some communities over others. So what you see on the left is a map of poverty in New York City. The darker greens and blues represent neighborhoods with greater proportions of people living below the federal poverty line. But of course, that metric has really not kept up with the true cost of living and represents a quite extreme level of poverty. In 2024, the federal poverty level for a family of 4 was just over $32,000 a year. Next to the poverty map, you see maps of the percentages of Black and Hispanic residents in New York City. High poverty neighborhoods, not surprisingly, knowing our history, overlap with the predominantly Black and Hispanic neighborhoods. And specifically, I just want to point out Central Brooklyn, which is right there. Excuse me. And that neighborhood specifically encompasses several majority Black neighborhoods and the mainly Hispanic neighborhoods of Upper Manhattan and the Bronx, which you see here. and here, again, show that same pattern as being some of the most impoverished neighborhoods in the city. So again, we've created a society where race and class are closely related, right? We know that in public health. And since the founding of the United States, we've exhibited the same profound indifference toward the well-being of Black, Indigenous, and people of color communities. The consequences of that indifference are embedded in the structural racism that's reflected in our political and economic systems. We're all operating in an economy that disregards, extracts, and degrades our collective health. And I know that we all agree, at least, it's time to change that, although it's pretty hard to do. At the New York City Health Department, we're doing what we can to build solutions to support New Yorkers' health and economic prosperity as two sides of the same coin. That means we're committed to driving resources to neighborhoods according to health, economic, and social need, as Dr. Kamara Jones likes to say. And to do so, we need to have a clear picture of how those needs are distributed across race and place. As we start to map different metrics of health and prosperity across our city, we certainly see very clearly how inequity in one aspect reinforces inequity in another. So, more maps. New York is known for its unaffordable housing market. In neighborhoods where a significant portion of residents fall below the federal poverty level that represents a completely unlivable wage, we see a greater frequency of court-ordered evictions. Safe and stable housing is a basic human need and human right. It has an enormous impact on our health, and it's the baseline condition from which many other health interventions and improvements can grow. Another map. Same pattern of inequity in food insecurity. Residents of poorer, majority Black and Hispanic neighborhoods are more frequently worried about being able to afford enough food for their households. And of course, this has worsened over recent years since the pandemic. If we look at SNAP enrollment in New York City, it's increased consistently for the past 5 years, since 2019. And again, the darkest blue neighborhoods indicate areas where more than half of residents are food insecure. And that takes a direct toll on health as well, of course, as does everything I mentioned already: housing insecurity, the threat of medical debt as a deterrent for seeking care, the psychological toll of racism, economic anxiety, and the combination of all of those things. So what I really want to say with all these maps, right, I wouldn't be a health commissioner if I didn't start with some data and some heat maps. But what's really important to say for New York City, of course, is that this is happening in the richest city, in the richest country in the world. We're surrounded by an immense level of wealth that remains very densely concentrated among an increasingly thin slice of the population. Particularly when it comes to poverty, as I mentioned, these are pretty conservative figures. Poverty in New York City is more accurately captured by metrics that take the high cost of living into account, which the federal poverty level does not. We urgently need a true cost of living standard to ensure that New York City government is accurately addressing the economic burdens of our constituents and the related health and social inequities. Robin Hood Foundation, which is kind of one of the big, it's a very interesting foundation. I don't know if any of you are familiar with Robin Hood, but it was founded by billionaires and millionaires as a anti-poverty foundation and intervention. And many of the board members and founders are people who are also donors to our current Republican Party and Donald Trump's campaign. So it is a very interesting foundation, let's just say, that's, I think, facing a lot more conflict than they have in the past in the current federal administration. But we do all often rely on their statistics around poverty in the city. And they just in 2025, earlier this year, released their annual poverty estimates. And they found that the city's overall poverty rate is 25%, which is nearly double the national poverty rate of 13%. Again, that's taking into account the high cost of living in New York City. So that's 1 in 4 people in New York City living in poverty. And in New York City, we also have 110 billionaires. The top 0.001% of the city's population are worth a collective $694 billion. And our city is home to more billionaires than anywhere else in the world, and yet more than 2 million New Yorkers can't afford to meet their basic needs. And half of the city is on Medicaid. 60% of our kids in New York City are on Medicaid, and more than half of the births to women in New York City are to women on Medicaid. So, this summer, when Congress passed H.R. 1, that includes devastating reductions to Medicaid, Medicaid, again, has become the most effective anti-poverty program to date. And although it's certainly not a perfect system, it's a system that is the foundation of our whole entire healthcare delivery and social system in New York City. It's the largest government program that recognizes the intrinsic link between financial and physical health. And Medicaid has been a lifeline for millions of people in our city. We're poised to keep as many of them on their health insurance as possible, but we're bracing for the impacts of devastating federal legislation. So that's New York City. The consequences of all of these immense inequities are taking years off of our collective lives. This is a map of the premature death rate, again, death before the age of 65 in New York City. Once again, we see that the most impoverished neighborhoods with the highest proportion of Black and Hispanic residents are the most affected areas. The blue outlines on this map represent areas served by our neighborhood health action centers, which Dr. Bassett started. These are brick and mortar centers located in priority zip codes. We've built out our physical presence to better serve the communities that have historically been abandoned or harmed by government policies and systems. And I know you all are quite familiar with this. If we were to stack all these maps, every single map that I've shown on top of each other, the overlapping areas become pretty clear. They are the boundaries of historically redlined communities in our city. And the bottom line, again, is that we're facing health inequities in lifetime that mirror historic inequities in resources. Our political and economic decisions have compounded over decades and generations. And we've created a reality where resources are so stratified that New Yorkers in one neighborhood can expect to live more than 10 years longer than residents of another. Key words being, we have created a reality. All of these maps of race, poverty, food insecurity, housing insecurity, premature death, et cetera, are the results of the policies and practices that have been created and maintained in our country. And certainly, most importantly, again, if we created it, we can change it. They don't have to look this way forever. And I certainly hope that 10, 15, 20, 30 years from now, we're not looking at the same maps. We're driving resources according to need in New York City, and we're determining how we can improve health outcomes citywide while prioritizing the areas that have been pushed to the back. All of our work aims to equitably improve the health of the city. And we have 8.5 million people in our very crowded city, and the New York City Health Department has about 7,000 staff and a $2 billion budget to do this. So what are we trying to do? What are we doing? Sometimes I have to ask myself that question. What are we doing again? So this is a snapshot of some of the interventions that we're pushing forward in the New York City Health Department, and all of them build on long-standing public health programs, policies, and services. To support the parents who are pregnant or who have young children, we've provided over 20,000 families with nurses and doulas for free. There's still a lot of unmet need, but 20,000 families is a pretty important number for us. To prevent foodborne illnesses, we inspect more than 30,000 food service locations for food safety, including restaurants and school cafeterias and food trucks. You're probably following that the CDC is pulling away from doing some of that work, so more important than ever that we keep it going in New York City. To inform our approach to public health interventions, we include more than 200,000 New Yorkers in our survey-based research, which is very, very cool and very exciting. In fact, one of the projects that I'm most excited about that we're working on right now is a project looking at, for the first time ever in the city and really in the country, looking at a representative sample of New Yorkers by the 13 most common ancestry groups, not just race, ethnicity, and looking specifically at their wealth not just their income, and looking at their self-reported health status, and really analyzing that together through a representative sample, and making that a routine part of our biannual community level sampling surveys. So trying to shift a little bit and not only look at income and really bring wealth in as a key indicator that we in public health should be monitoring and following and looking at by ancestry group. And as you know, in New York City, we've got just about every ancestry group that ever existed, which is amazing. So to ensure that every child in New York City has access to vaccines, we distribute more than 2.5 million doses of pediatric vaccines to more than 1,000 different health providers through our Vaccine for Children program. It represents about a $233 million federal investment. As you are very aware, it is at extreme risk right now. 75% of the kids in New York City are eligible for the Vaccine for Children program. So we've got some big challenges there. To prevent overdose deaths, we distribute more than 300,000 naloxone kits and more than 54,000 fentanyl test strips. And to meet New Yorkers where they are and build trust on the ground, we've equipped more than 5,000 community health workers to join our public health corps. As you guys know very well, in our field, our greatest successes are crises averted. So that can make our work a little bit hard of a story to tell. But I would say that one of the most important large-scale metrics that we're looking at is life expectancy, of course, and I know you guys are quite familiar with this one. This is our most recent data on life expectancy by race and ethnicity in New York City. And overarching goals for us include equitably increasing lifespan in New York City to 83 years, bless you, by 2030, after losing significant life expectancy during the pandemic. Now, the good news is that we have our data from 2023 showing the changes in life expectancy. And our 2023 data, which is our most recent data, shows that we've recovered our life expectancy to almost exactly where it was pre-pandemic. So that is very exciting. And in November, we'll be releasing our 2024 life expectancy data, which spoiler alert, shows that we're continuing to see improvements in life expectancy. All of that, I would say, is at risk because of all the policy changes that are happening right now, but at least in the recent data, we have seen really positive improvements in life expectancy. So on the other hand, what you also see in this graph is the dramatic and long-standing racial inequity in lifespan. Black New Yorkers are still dying more than 5 years earlier than white New Yorkers. This has not changed, by the way, since the New York City Health Department started measuring life expectancy by race. So Black New Yorkers have always had a significantly lower life expectancy. All of these inequities, which reinforce one another, really were a big part of the first big initiative I got to be a part of when I joined the New York City Health Department about 4.5 years ago. And it was our declaration of racism as a public health crisis that was passed by our Board of Health. One line particularly worth highlighting here is, whereas racism is a race-explicit system and anti-racism requires race-explicit strategies, and we have a lot of work to do. One of the most damning consequences, of course, of racism in a capitalist society is the stratification of resources. And our race-explicit strategies have to also be class-conscious. Our work in the health department is grounded both in anti-racism and anti-poverty, and I'm sure you guys would agree that they go hand in hand. And as I mentioned, one of the things that I'm most excited about is our work on the racial wealth gap. This is the wealth distribution by race in America, where the typical white family holds more than 6 times the wealth of a Black family. Closing the racial wealth gap and transforming its effect on public health will take a whole lot of strategies at once and feels quite distant in our current political landscape. But we need bold policy interventions like reparations, baby bonds, and universal health care. We need to make wealth and health data collection and analysis a core public health function. And we need increased community ownership over the methods of healthcare delivery, which are overwhelmingly and increasingly privatized in our country. These are massive, large-scale societal changes, but they're possible. Again, if we created it, we can change it. And it might feel out of touch to talk about these large-scale changes in a moment of political crisis, or maybe more than a moment at this point. But it is eras like these, when the failures of our existing systems are laid bare, when change is most possible. This is when it becomes painfully clear that nothing about the vast inequities I've just described are accidental. These are inequities that have been engineered by systems that created, preserved, and exacerbated social stratification for centuries in this country. And we built those systems so we can reimagine them. And it's kind of interesting, again, to be saying this back home in Philly, where like right down the street is the Liberty Bell and all of the like founding monuments. And next year is the, I think, 250-year anniversary, right, of our country's founding. So we have a lot to do. Maybe a new constitution's in order. So if we're going to build healthy cities, we're going to have to get creative. This is just a brief case study from New York City to illustrate how we can create new systems that acknowledge the shortcomings of past public health approaches, because our history as a discipline has not been all rosy. I hope that's not your takeaway. But I also do want to say that part of the reason I believe so much in community health worker models is because before coming to New York City, I spent the majority of my kind of first 15 years of my work working in Haiti and Rwanda and Botswana and several other places, including kind of being, I would say, activated by being a member of ACT UP Philly back in the day when I was a med student here. And I worked with Partners in Health and Amis La Santé in Haiti, and I lived there for several years. And that's really where I learned what community health workers could do. And how far off our healthcare delivery system is in the US from where it needs to be. So this example is very close to my heart. We created a program called Public Health Corps during the rollout of COVID-19 vaccines. Of course, like many other places, we saw profound racial differences in vaccination rates. And our vaccine rollout in New York City was coming from a government voice. Most of the Black and Hispanic and people of color communities in New York City had a pretty profound lack of confidence in government, quite naturally. And a lot of public health services, of course, had really failed them. We, of course, like many other local health departments, including Philly, knew that we needed to create a program to really get over that and address that issue. Or begin to address it. So we created the Public Health Corps and partnered with local organizations, community-based organizations, and funded over 100 community-based organizations with over $100 million back in 2021, 2022, and 2023 to really be the vanguard of our COVID vaccination, education, prevention, and healthcare connection efforts. Those community health workers allowed for millions in those federal COVID dollars to reach places that had been systematically excluded from receiving federal dollars. Our community health workers, like the one you see here, provided testing, vaccine education and connection, PPE distribution, and we saw our vaccination gaps close. The Public Health Corps has become an integral part of our work, and through it, we've connected more than 1 million people to vaccination sites since the program's creation in 2021. And that sounds like a big number, but it's only 1 in 8 New Yorkers, so New York City is always a challenge when it comes to scale. We've also referred hundreds of thousands of people to resources that meet their social needs, including food, health insurance, and housing support. Because of this, and the success that we saw with Public Health Corps during the COVID pandemic emergency response, as the emergency phase of COVID became clear, we shifted our Public Health Corps program to focus on chronic disease. The idea being, like, how could we mobilize this massive community-led, community health worker, community-based organization response and then just let it go away when there's so much that we learned, so many relationships that were built, and so many things that changed. So now we still do a little bit of vaccine access, although again, with the COVID vaccine being where it is, I'm not sure what that's going to look like this fall. But we've gone into all kinds of other areas of work that community health workers are best suited to lead. Things like diabetes prevention and diabetes management, blood pressure monitoring and treatment, asthma care. And again, our community health workers at the health department are based in the community. They're not health care based. They're not based in clinics or hospitals. So that is a really important change. And they allow us, of course, to also connect New Yorkers to food, employment, mental health services, and so many other things. Last year alone, we partnered with 21 community-based organizations and 25 clinical sites as a part of Public Health Corps. And in 2024, our community health workers reached over 350,000 community members, provided over 75,000 health education activities, and made over 200,000 referrals for vaccination, healthcare, and social services. I'm proud of this work because not only is an example of shifting emergency response infrastructure to focusing on ongoing, chronic, slow-burning public health emergencies, but to me, it also really brings the model that I learned at Partners in Health in Haiti and Rwanda and Botswana into reality in a way in New York City that we could really use it. So I'm hopeful that the impact of these community health worker programs can be big in the years ahead. Our community health workers are positioned to have a big systemic impact on the health of our city. Our research projects that scale our community health worker network to 10,000 workers by 2030 could serve 1.5 million New Yorkers and save nearly $2 billion in annual health system costs. Again, that's if we're able to do it. Going from what we currently have to 10,000 community health workers is going to take serious resources and commitment. But our Public Health Corps would allow us to deliver this individually and culturally responsive care to New Yorkers that we are serving. I hope this program will allow us to, again, also demonstrate that trust is gained in drops and lost in buckets. Our community health workers are building one-on-one connections and earning New Yorkers' trust drop by drop. In our field, of course, we're seeking to realize big changes, but those changes always unfold and start in small ways, especially when we're up against inequities that are so vast that they sometimes seem immutable. So just to close out, I'll close where I started, here at home in Philly. In the spirit of making big changes in small ways, I wanted to zoom out about what building healthy cities could really look like. Ultimately, one of the central questions driving this convening today, yesterday and today, is what would it look like to have a city and to live in a city that's not stratified by race, class, gender, geography, nationality, et cetera. That is, of course, the question, and it can be answered in many, many, many different ways. But for me, the answer is encapsulated, of course, in something small. At some point in my work in Rwanda, I learned about the practice of the Maasai tribe in Kenya and Tanzania. And that tribe has a customary greeting to ask about the broader community, but certainly most importantly about the prosperity of the next generation. And that greeting is, and how are the children? I think it's something we should all be asking. How are our children right now? And I hope that at some point we'll be able to live in a city, in a world, in a country where we can say that the children are well. So thank you again for your time, and I'm happy to answer any questions.
Thank you so much, Dr. Morse,
Thank you.
for your profound words to start us off this morning. Now we'll take a few questions, if anyone has them. I'm happy to bring the mic to you. Yeah. All right. Oh, yeah.
Thank you for your talk, and my question's based on where you ended right here about trying to imagine a city where there's no health inequities. Because I was approached by a public health, excuse me, official in my city who is asking this very same question. He doesn't want to share like targets, or he doesn't want to share performance indicators. He wants us to be able to tell stories about what our community would look like if we had health equity. And he asked me, how do we do this with data, maps, visualizations, he even imagines VR? How do we get better at taking the evidence we're gathering and tell these compelling stories that will help people imagine a future like you're describing?
I think that is such a phenomenal question. And I think it is very hard to describe sometimes kind of the way public health interventions really can shape health and reshape health. I think it's often even just hard to like define public health, right? Like, and we all, have our own definitions. But from my perspective, so much of it is, really digging into the past in public health, honestly. Really taking a critical eye to what's worked and what hasn't worked in our field over, several hundred years. And I do think part of that is being able to acknowledge the critique by many communities, many marginalized communities, that our approach has been paternalistic, extractive, give us your data, give us your ideas, and we will fix it for you. And that's not just true in public health. I think that's true in many disciplines. But I think if we were able to really examine that deeply, that's a starting point for the narrative. But then we have to be able to show the end of the arc. Well, what's the alternative? How have we done it differently? And I do think there are interventions out there that are doing it differently. I will say we had Dr. Tom Farley, who I know you all know, from his time as commissioner here. He came and spoke at New York City's, at our commissioner's grand rounds. And one of the things that I really appreciated, actually, that he did was he showed 3 examples with beautiful pictures and narrative and a little bit of data of profoundly impactful, life-saving public health interventions. One of them was the window guard story in New York City, where, in the 80s, unfortunately, like hundreds of kids were dying from falling out of windows in tall, buildings in the Bronx and Harlem, and kind of what the public health story and intervention was to try to address that, and a couple of others. That might sound outdated because we don't even worry about that now, but it is an example of both like how we could tell the story with a narrative, and the reason that whole intervention started was because communities in the Bronx in New York City were saying this is horrific, like this should not be happening. Why is this happening? Why is it happening here? So I think telling the story of those successes, again, with mostly pictures, community narratives, and maybe a little touch of data, creates a new way of talking about the things we're doing right now that are life-saving, and we don't talk about our successes enough.
Yeah. Thank you. Okay, thank you.
Hi, I really, really appreciate your talk and your comments. I have a question as a academic who's based in New York. On the commissioners panel yesterday, the topic came up about kind of what they need from their academic partners to really help kind of fight the fight. It strikes me that things may be slightly different in New York, and I know in my case, I depend very heavily on the epi briefs that you all produce, as opposed to kind of you all waiting for my data per se. So I'm curious, like, are there things that you are looking for from your academic partners in the city? What are the things that we can do to kind of help as well?
It's such a great question. And you're right, I mean, New York City has so many universities. I'm still a very new New Yorker, having only been there for 4.5 years, and I could not tell you the majority of the universities and what their focus is, honestly. So it's a very complex landscape. But I will also say kind of part of what I find challenging, and I'm like a reformed academic myself. I used to be a program director for a residency and do a lot of teaching and training. I think the first thing is that a lot of times the leadership of universities doesn't always like see the value in doing frontline implementation-oriented research or research that like, you know, is maybe not the most cutting-edge thing at the NIH or wherever, or the CDC, but is the kind of research that has real human impact. I think until that mindset changes, it's like very hard to imagine a future where academia like has a more meaningful role in public health. So I think that's one thing, is like kind of how does the leadership of the university conceive of the value of public health work and public health science and research. Another is honestly, I feel like I spend a lot of my time as acting commissioner kind of talking to academic audiences and having great dialogue. But usually that leads to, hey, can you write a letter of support for this grant that I want to do that's completely unrelated to every priority you just shared in every talk that you've ever given. So that's frankly like a big challenge. But again, I think that requires the university leadership to make a meaningful commitment, not just a verbal commitment, but a meaningful commitment to working on the priorities that are set by local health departments. And then the third, to me, like the most exciting part of public health right now is that young people are really interested in it. We had the largest number of applicants to our internship program this year than we've ever had in history. And we only had, I think, like 100 spots or something, so that's something I'm working on. But it was like a 2% acceptance rate for our internship, which I was like, that's like more competitive than medical school, which is a big problem. So anyway, so I do think like that's a huge opportunity, is how could we have more students really involved in frontline work in local health departments, and I'm hoping we'll be able to do that like quite soon in New York City. So yeah, thank you.
Wonderful talk. So speaking on your last point about involving more students, what is New York City doing with bringing especially immigrants or kids from immigrant backgrounds? Because I think there's I think you will know that there's a lot of gaps, especially focused on immigrants, and if there was more in the pipeline, more junior people in the pipeline, they could help to close the bridge in the
Absolutely.
future. Yeah.
I would say not enough, quite frankly, and this is where our local politics has been a real challenge over the past several years. I believe the latest number I heard was that we had about 220,000 new New Yorkers spend time in the city in some way, shape, or form over the past 4 years, when that very challenging situation with Texas sending folks, either like voluntarily or not, to northern cities happened. And that spurred a political crisis unlike anything I've ever witnessed and seen. It almost led to me leaving the health department, quite frankly, because it was, the narrative was these people don't deserve to be here. And it really politicized asylees in a way that was extremely challenging. And despite that, the good thing about New York City is our sanctuary city laws and the right to shelter, which was shaken pretty significantly. The right to shelter in New York City is kind of one of the most important human rights laws we have on the books, and it just basically says that no one should be sleeping outside. Everyone has the right to a bed inside a shelter. So not enough, but a lot of that is the politics. Our general election for mayor is in 8 weeks. And I know a lot of people are watching. But the politics of that were very difficult. Despite that, I will also say what we tried to do in the health department was, our classic public health work, the surveys, the frontline services, the support, applying for asylum and health insurance, A lot of work in our shelters. Our shelter population grew from an average of about 40,000 to about 90,000. At one point it was 100,000. We're now down to about 60,000 or so, but that's still 50% more than pre-COVID. So all of that said, I think it's just been very challenging. But what we were able to do, and I'd encourage you guys to take a look, we spent about 2 years developing an immigrant health report. It's the first time we've done that in about 10 years. That was put out publicly in April. It took a lot to get it approved for publication, but we did a lot of engagement around that report. And some of the top lines that I'll mention, 1 in 3 New Yorkers identify as an immigrant. 47% of our frontline health workers, doctors, nurses, technicians are immigrants, 47%. And, there are massive inequities in insurance enrollment, et cetera, by immigration status that were very clearly highlighted in that report as well. And right now, we are nearing the end of a listening tour where me, our Commissioner of Immigrant Affairs, and the person who leads a program called NYC Cares, which is kind of like a alternative to health insurance for people who are undocumented in our public hospital to get care in our public hospital system. We have been doing a listening tour where we meet with community-based organizations and community members in each borough to hear from them about their concerns about their health access and health issues. And that has been very informative as well. So we have a lot more to do.
Thank you so much for your time and for this phenomenal keynote. My question to you, it's kind of building off of Mariana, thinking about trainees and graduate students because they're here in the audience. We're training them here at Dornsife. What advice would you give to them right now, given the current landscape of public health and how our field is directly under attack? And it was great to hear that you said that this year you saw such an increase in the interest in public health and you said young, we're all young, I'm young, but I know what you mean. That's really great. That gives me hope. But I recognize the stress that the current students that we have in our program, what their outlook looks like. So if you could share any words of encouragement or advice or perspective, given where we are on this Friday, because every day.
Yes, every day is a struggle these days. But yes, first, it's the same. For me, like the thing that gives me hope for sure is that. And I'm from a family of public school teachers, and so for me, of course, like thinking about, what the future holds for the next generation is so central. I think it is pretty hard, right, between, our current political era, climate, and so many other things. But I really do actually believe what I said, that it is in like very, very challenging times like this that the most transformative changes are possible. So I do think for us young people, we do have a chance to redefine the field. And I think it would be very sad if we shrunk our ambitions for systemic change because of the conditions we're facing right now. I think it's a time, especially for young people. If young people don't push us to do this, it's not going to happen. We have to demand universal health care, right? It sounds crazy, but like, when else is it possible except for when our whole entire system is literally going to implode once the HR1 kind of implementation happens, right? So I think we have to not tamper our ambitions and our vision. And the only people that are going to make sure that happens, of course, is the next generation. So, yeah. Hi, Sterling.
Hi, Michelle. Yes, thank you for the presentation. It's good to hear what's happening in New York. And just reading the news of the last few days, it's and in the last few months, there's just been a gutting of CDC and NIH, and it seemed as if California, Oregon, and Washington are coming together to make some sort of knowledge producing, or I don't know
Something.
whether it's something, but and I kind of think about like, oh, what could we kind of have going on this coast, either in
Yeah.
collaboration across jurisdictions or something, and so
Love it.
I know that maybe you don't have an answer, but I don't know, maybe I'm just dreaming about what is possible, with probably New York leading this on the East Coast. And that's all.
Yeah,
Thank
no,
you.
thank you for that question. I think that is exactly right. I think if the CDC continues to be undermined, weakened, defunded, which I think all of us we're expecting that trend to continue. Unfortunately, there's balls that are going to be dropped. So how can we pick them up and keep running, right? And how can we make sure that some of those really critical functions of the CDC don't get dropped? I will also say, I am really scared that other states are going to do what Florida is saying it's going to do and end vaccine mandates. That makes us all less safe, and it does mean regionally we need to get together. So interestingly, there is a Northeast regional collaborative that is coming together slowly but surely. I think I would say accelerating with everything that's happening. And we had our first in-person meeting in mid-August in Rhode Island. There have been some media reports of it, but we're trying to work to kind of have a formal announcement, essentially, about it. But it's 10 states and New York City, so it's from Maine to New Jersey, all of those states and their commissioners plus me for New York City. And that group of states and cities represents, I think the count is 57 million people. So it's 1 in 6 or 1 in 7 Americans. And the idea is, let's share data. Let's think about, purchasing vaccines together if we need to. And let's think about strategic stockpiling and some policy stuff too. So I think it's going to accelerate. Now, it certainly can't replace the CDC, and the federal government still has a lot of power to undermine even a regional collaborative like this, but I do think it's going to be very meaningful at a minimum for relationships and morale and surviving what this era is shaping up to look like in public health. So thank you. Yeah. Thank you all. I really appreciate the opportunity to be here.
Thank you so much.